I'm Dr. Mark Murphy, and I'm joined by Dr. Andy Lyne, and we're both members of Irish Doctors Supporting Medical Assistance in Dying. Andy, how are you this morning?
Good morning, Mark. Nice to see you, and thank you for inviting me for this chat.
There's a lot happening as of December 2024. We have the Joint Oireachtas Committee report on assisted dying earlier this year. We just voted last week, and I guess we have a variety of parties who are kind of busy trying to form a new government, and there will be a program for government in the coming month or two. And we are anticipating that in that program for government, a plan will be put in place to legislate for voluntary assisted dying, which is the summary recommendation from the Joint Committee. And in that context, I think our group has we have outlined a model of care about how voluntary assisted dying could operate in Ireland. So we might try and walk through how that would work in the Irish context.
I think we what we might do is we might discuss, we might go through the criteria that has been proposed by the Joint Oireachtas Committee. Then we might go about how an application and an assessment might take place, and then how the provision of assisted dying may occur, and then finally to make some comments about and suggestions about other ideas and improvements we may have on the Oireachtas report.
Okay, so to start with, a patient at the moment, and the Joint Oireachtas Committee, we're roughly in line with what a lot of their recommendations are in terms of eligibility criteria. But essentially, it's an adult with an incurable condition. So this would be someone who's dying of a medical condition. Only they can apply for voluntary assisted dying.
Yes, I mean, the criteria as laid out is quite restrictive. It's restricted to adults, it's restricted to people who have a terminal illness and are who are suffering from that terminal illness and and have a limited prognosis. And I think it's also restricted to people who would normally be resident in the Ireland of Ireland. And those individuals have to have capacity. They have to have the ability to make this choice. And that's, I think, a fundamental part of uh,
Yeah.
the.
And if our group had one thing to chip in on the Joint Oireachtas Committee report, we would say that those who are eligible should be resident on the island of Ireland. So I think the report just suggested the Republic of Ireland, but we do suggest that it should be anyone who's ordinarily resident over 1 year on the island. In terms of capacity, I guess just to be very specific about this, only a minority of the 17, 18 countries internationally allow for voluntary assisted dying for dementia, for specifically for someone who has cognitive impairment. So I guess the majority of the Irish public would support that, and many doctors do as well. But our group um, would support, at least initially, the introduction of voluntary assisted dying um, for only those individuals who have capacity, both at application and then also when made would be provided.
Right. I think everywhere um, it is important that it is the patient's wish and it's their choice. And obviously, with dementia, there's an issue with capacity, as in it may be a person's choice and their wish, but resolving the issue regarding capacity can be difficult. Now, we think it is an issue that should be resolved over time,
Sure. Mm.
and there may be a place for advanced care directives at a future date. But I think it's a very difficult issue to resolve, I think, fully. And I think at this stage, we shouldn't recommend something that we don't have all the answers to. And when it comes to dealing with people who are dying with dementia, and I certainly know I myself would hate to live through the end of, to have an end of life care with advanced dementia, because I think it's a very distressing situation for both the patient and for the family. But this issue regarding capacity is a difficult one to resolve. And I
Yeah.
think it's important that we recognize it, but also acknowledge that at this juncture, at this time and moment, I think it's important that that the patient has capacity.
Yeah, and we might mention this. Obviously, we fully support a review process, and we believe it should be in 3 years' time. But we can see what the emerging evidence is internationally, and we can our legislation should evolve, which will be, democratic and evidence-based. But at the moment, that's we would support the Joint Directors Committee on that. And we also excluded mental health as a mental health condition as a qualifying condition under the legislation. That should be excluded. Um,
Yeah, I think that reflects the opinion of most of our members.
yeah.
It's a very, again, it's just a very difficult area to legislate for and to regulate for. So we feel it's best to exclude that at this moment.
We've heard from providers internationally, over the last few years when we've been training our own members on voluntary assisted dying, that one of the largest burdens on a registered medical professional, the provider of voluntary assisted dying and the assessors of applications, is that there's a significant amount of administration and paperwork, which is appropriate because this is, needs to be heavily regulated. But I guess all that administration and the various steps and safeguards, they can theoretically and practically impose a lengthy time frame in terms of the application process. So I guess we would like kind of a minimum standard, to reflect of time to ensure that patients aren't disproportionately waiting. Remembering that these are patients are dying of a condition and they shouldn't be waiting months for this process.
Well, I think it's very important that the assessment the assessment is robust, but at the same time, we need to be careful not to put in
Mm.
hurdles and barriers to patient accessing assisted dying appropriately. And we are dealing with people who are frail. They are in the process of dying by definition. And if you put in a lengthy, complicated, Byzantine system that frustrates them, then we're causing people to suffer unnecessarily. And I think people would become very frustrated with that. I think when we look at the Australian model, where
Mm.
you have two assessments by two independent doctors, there's generally some form of waiting period built within that. It varies from state to state in Australia, in and around a 2 week period of time for the assessments to take place. That to me would seem quite appropriate, because over the 2 weeks they would need to request assisted dying on a minimum of three separate occasions. So we
Yeah.
can be confident that their choice here is an enduring one, and not, and I think that is important.
And I guess our proposal of a 2 day wait period of a 2 week period seems appropriate. But equally, there will be exceptional cases when a terminal illness might be expected imminently, and maybe an expedited process in such cases should be available under our legislation.
Yes, again, in the Australian states, they all have slightly different tweaks on this, but by and large, they all allow for a, a reduction or to put aside the waiting period if someone's life expectancy is very short, such as a couple of weeks or 4 weeks, would typically be what is mentioned. And again, that's entirely appropriate.
And Andy, just to go into the two assessments, so they would typically be a family physician or a GP like ourselves, and there would be a collection of trained professionals, registered medical professionals who could provide this assessment in the community. So we might just talk through what exactly would happen in that assessment, just so people would know how that would operate.
Well, I guess the assessment would be done by two separate doctors who would have to be, excuse me, independent of each other. The assessment would be to make sure that the patient reaches the criteria, qualifying criteria, that they have a terminal illness, that their prognosis is less than the 6 months or 12 months, depending on the condition. They would also want to assess that it is the patient's true wish, that there's no evidence of any coercion, that it's not anybody else trying to persuade them, that it actually reflects the genuine wish of the patient.
Mm.
It's important to explore the patient's understanding of their illness, their expectations of what might happen. It's important to uh, ex- go through other options with them. Have they considered palliative care? Have they, what are their fears? And to explore those fears and see if assisted dying is truly the right option for them. And when all that is done, you then repeat that with a second doctor a week or 2 weeks later. And then that, I think, gives the patient time to reflect on whether or not this is the right choice for them.
And we know from both Australia and Canada, approximately 4 out of 5 applicants for voluntary assisted dying are also in receipt of palliative care in parallel. So it's not an either or. These are patients who are dying of a medical condition, probably have their GP, medical specialists are engaging in palliative care, but this is just another for these individuals. They're just activating another option.
I think for many individuals, it would be nice to have it in your back pocket. That
Mm.
if the suffering becomes too much, whether it's suffering through pain or through shortness of breath, or maybe it's suffering through simply the fact that you're incapacitated and unable to do, your day-to-day activities, such as go to the toilet or feed yourself. And for many of us, we would not like to necessarily live through that suffering, knowing that our death is at the end of that suffering, that there's no prospect of recovery. And I, so I think for many people, it may bring them comfort just to know that that choice is there if it becomes too much. And certainly, just because one wants to have the choice of assisted dying, and again, as you say, from international experience, most people will have access and benefit from palliative care.
Just to say two other things about the assessors, I guess these registered medical professionals, we will need to introduce as part of the implementation program after legislation is introduced, uh, processes regarding how we are supported. So there will need to be education, training, professional supports, peer supports, and that's we can model that on other countries that have implemented this before. But it's really important that these doctors and the multidisciplinary team are supported in our professional um, training requirements.
I think we can certainly learn from Australia and New Zealand. They're very similar, cultural and medical practices to our own, and it'll be, I think, relatively easy for us to adopt their training protocols to
Uh,
apply them to the Irish context.
and it's for the majority of patients, these two medical assessments would be sufficient in terms of deeming whether or not a patient is eligible. But there will be rare situations in which there might be uncertainty regarding capacity, and I guess as part of this process, it would be useful to have other specialists available if needed in terms of assessment, maybe a medicine for the elderly consultant, but for the most part, that professional would not be needed as part of the application.
Yeah, and I think for most of the time, as family doctors, we're well used to assessing capacity, but I think we'll always have the occasional difficult case, and it would be useful to have access to as you say, a specialist in medicine of the elderly or perhaps a psychiatrist. But for example, in New Zealand, in their first year, there was 4 patients were referred on for psychiatric opinion regarding capacity, and 3 of them were found to have capacity, and the fourth person died while they were waiting that assessment. So I think it is something that wouldn't happen on a frequent basis, but I think it would be a useful resource for the assessors.
Mm. And at any stage along this journey, the patient is central and they might want to pull out of the process and that will be allowed. But assuming they want to continue this process and the two applications, In our proposed model, there would be a central committee that would screen and view the paperwork and also the eligibility criteria from the two assessors, and a decision would be granted, a certificate as such, that would be communicated to the patient and to the medical assessors. So I guess if voluntary assisted dying is not approved, um, there would need to be I guess an appeal process for the patient in that setting. So that wasn't stipulated in the Joint Oireachtas Committee, but that would be a logical um, part of the legislation, that an appeal process should be there in case, just so a patient could appeal it. Um,
Yes, I think as you say, it's a logical um, option to have, that a patient would be able to appeal if they've been declined, and I think that would make it easier on the assessors too, because I think it if you decline a patient, at least they have that option to appeal, and I think that would be very useful for both the patients and for the assessors.
um, it's really important that for the public and for patients that a safeguard is present, that there would be sanctions against registered medical providers like ourselves in case we acted outside of the legislation. And I think we're really supportive as a group of appropriate sanctions to make sure that we operate professionally. And I guess those sanctions might also apply to family members. So we support that. But there's also a balance, isn't there, in terms of making sure that there isn't a disproportionate, um, chilling effect on a doctor like ourselves. Um,
Yeah, no, I think any sanctions need to be appropriate, proportional and appropriate. I think none of us want to see anybody being coerced into any decision in their medical treatment, whether it's whatever that treatment is, including assisted dying. I think it's important that we emphasize that that respecting the patient's autonomy is paramount at all times. So I think it is important that if there is significant transgressions under the legislation, that there's robust and significant sanction. But if there's minor infringements where a person may have an issue with paperwork, or then I think the sanctions should reflect this the seriousness or lack of any transgression.
as one example, for the 38 recommendations in the Joint Oireachtas Committee report, we have published a paper this month in December 2024, just discussing our reaction to some of those recommendations and maybe suggested edits. But just one recommendation as an example, recommendation 3 states that a person would commit a criminal offence if they fail to adhere to the relevant statutory requirements. So I guess as if you take that recommendation literally, if I, for example, was to fill in a date incorrectly on in one of the administrative forms, technically by the letter of that recommendation, I could have committed a criminal offence. Now, clearly, I should be sanctioned. There should be a professional response. I have to, but I also should be supported as a provider, and we have to just have proportionate sanctions available. We heard from a doctor at the recent World Federation of Right to Die Societies, World Federation of Right to Die Societies conference in Dublin. One Australian doctor faced a five-figure Australian dollar fine for a basic administrative error. At least that isn't a criminal sanction, but you can see that the sanctions have to be appropriate because we have to support doctors to provide this into the future.
Absolutely.
Um, so moving on, I guess there as part of the implementation process, a governance structure will have to be created to support all this new service.
Yeah, no, I think it's important that there is a separate organization to monitor and to report on assisted dying. It's important that we have data and it's important that we have transparency because in that we can create trust. And I think that is crucial when we look at going forward with assisted dying. And certainly, when you look at the Canadian experience and the amount of information we can see from Canada, because they're very good at reporting it in a fairly timely manner, I think that has been hugely beneficial. And that will add, of course, to our ability to do research into assisted dying and to, I think, if we're reviewing it, that we can consider changes to improve the provision going forward.
And we would also recommend that grants are made available to independent academic institutions put out to tender to for a mixed methods approach to assessing the the quality and the impact for service users and their families. So it's really important that there's a independent research that looks at this to make sure that what we're doing is evidence-based and in line with best practice. So, and Andy, do you want to just walk us through how the provision of voluntary assisted dying might operate in our proposed model?
Well, essentially, the patient would have a choice. We believe the patient should have a choice of either taking oral medication or receiving the medication intravenously. Now, when we look at countries where the patient is given that choice freely, the vast majority, typically more than 95%, will choose to have it intravenously. And that's because it's a much more effective method of administration. It is very reliable. It's very consistent in its effects, and the patient can be guaranteed a very peaceful ending to their life. And I think it is important that that choice is made available to people. That can happen either in their own home or the doctor could attend to them, in a nursing home or perhaps in a hospital or hospice setting.
So Andy, it's a very complicated. So our model is quite simple in some respects, and it's underpinned by multiple safeguards that ensure for the public and also for families and for patients that an effective and safe voluntary assisted dying process is at play. I just want to touch upon a couple of issues. The first is coercion, and the Joint Oireachtas Committee report on assisted dying mentioned this. I do feel that they failed to understand that coercion is a multi-directional process. Clearly, a physician or a family member coercing a patient towards voluntary assisted dying is something that we have to be alive to. It's one of the key issues in terms of assessment. But we know as GPs that coercion happens in multiple directions.
Yeah, and I mean, I think we're all concerned about coercion of anybody who's vulnerable. But when you look at the experience of countries where they have assisted dying, coercion of patients to have an assisted death is not a recognized problem. Particularly when you're putting in a prognostic clause, there really isn't an incentive for anyone to coerce anybody into an assisted dying when they're already in the process of dying anyway. And so it's right to be worried and concerned about possible coercion, but it's important also not to create fear about coercion when there's no basis for that fear. When you look into the experience of other countries, coercion has not been a significant problem.
I might move on to the issue of disabilities. Um,
Well, I mean, I think when you look at it, the qualifying criteria quite clearly states does not mention disability at all. And that's because disability is not a considered qualifying criteria, full stop. And while I think ratifying the UN Convention on Disability, people with disability, the rights for people with disability is something I completely agree with. I think there's really no association with provision of assisted dying. Assisted dying should be available for everybody who's, no matter what their level of ability or disability, and it is restricted to those who are actually dying. And I think to deny people the choice of assisted dying, whether they're fully abled or disabled, to me makes no sense. There is, we are not including disability as a qualifying criteria. It is confined to those who have a terminal illness. And I think this is a distraction from what is important here.
And paradoxically, that recommendation would discriminate against individuals who have a disability, and we really have to take a strong line to say that persons with a disability who end up with who unfortunately suffer from an incurable terminal condition and they are in the process of dying, those individuals have a right to access voluntary assisted dying like any other individual. And I think that recommendation really is kind of an obstruction to care, particularly for a vulnerable group. Um, it's also worth saying that studies on assisted dying have repeatedly shown that vulnerable groups are underrepresented in those who choose assisted dying. People who choose assisted dying are typically those of higher socioeconomic status. They normally have their own housing. They're in married and supported relationships. They have higher, they've obtained higher levels of educational attainment, and vulnerable groups and those who have disabilities are not overrepresented in those statistics. And it's important to really reiterate that when we talk about this and assisted dying.
Yeah, absolutely, Mark. I mean, quite clearly, our criteria does not mention disability, and disability would not be a qualifying criteria for assisted dying, full stop. And when you look at the international experience, where you look at people who have availed of assisted dying, uh, vulnerable groups such as those with disability are not overrepresented within that within people applying for assisted dying. People applying for assisted dying tend to be have higher incomes, more likely to be married, more likely to be living at home. These are not the characteristics of vulnerable people. These are characteristics of people who are being empowered by their families to make a choice that is their choice.
So, just to talk about palliative care services, the Joint Oireachtas Committee has about five recommendations relating to palliative care and supporting palliative care. And I guess Irish doctors supporting medical assistance in dying, we fully support the appropriate and full funding of palliative care nationally.
Again, when you talk about the international experience of where assisted dying is in place, uh, palliative care services have generally been improved since the introduction of assisted dying. And it is important that patients have the choice, that they have a choice of palliative care and they have a choice of assisted dying. Currently, however, we're denying patients that choice of an assisted death. And if that is their choice, that should be respected. And absolutely, it isn't an either or. I mean, palliative care and a patient should be able to avail of palliative care. And if they choose an assisted death at the end of that, then that should be their choice. And again, when we look at the international experience, um, the vast majority of patients who choose assisted dying have also availed, as you say, somewhere in the region of 80–90% have availed of palliative care. I think regarding palliative care itself, when you look at jurisdictions like Canada and Australia and New Zealand, although there can be quite resistant to the introduction of assisted dying initially, over time I think they see that it is a valuable choice for patients, and you're certainly seeing a softening of attitudes in those jurisdictions. So now, for example, in New Zealand, in Auckland, one of the hospices will provide assisted dying within the premises, and two of the other hospices have facilitated the assessments to take place within the hospice. And I think this is again just respecting patient autonomy.
It's really welcome that it looks like in the United Kingdom, voluntary assisted dying. will soon be implemented following the debate in their parliament last week. Um, but we did hear from some of the palliative care community that we need full resourcing of palliative care services first, full stop, before voluntary assisted dying can be introduced. And I think just to reiterate, we fully support the full resourcing of palliative care services. But from what you're saying, Andy, it is never the lack of access to palliative care services that pushes someone towards voluntary assisted dying, because in all the other jurisdictions, patients who choose voluntary assisted dying are also in receipt of palliative care at the same time. So we can be very confident that is not a lack of access to palliative care services that patients end up choosing voluntary assisted dying. Our group, Irish Doctors Supporting Medical Assistance in Dying, we believe that we can't hold individuals hostage to systemic failings in the health system, particularly the most vulnerable citizens. These are patients who are suffering from an incurable and terminal illness. Um, like rendering the provision of voluntary assisted dying conditional on the universal availability of the highest quality of palliative care. It's illogical and it's unhelpful. Um, like we can't just wait for a panacea um, in all aspects of healthcare before we provide access to voluntary assisted dying. Um, Notwithstanding all that, we still fully support, we're GPs and we provide palliative care services. The fu- we have to adequately support the funding of palliative care. It's very reassuring that in all jurisdictions where voluntary assisted dying has been introduced, actually funding for palliative care services has increased in those jurisdictions. So I think that should alleviate concerns in the public, and some of the scaremongering that has taken place from opponents to voluntary assisted dying. So our group has published a lengthy report in December
Mm,
2024, and we have re-articulated what we believe is an appropriate model of care for voluntary assisted
mm,
dying. Um, We've also responded to the Joint Oireachtas Committee report.
mm.
And whilst many of the recommendations are very sensible and we support, we also believe that they haven't gone far enough on some of those recommendations. And we have additional recommendations. Some recommendations we also feel are disproportionately designed to obstruct care. And where that takes place, we've articulated what we believe would be appropriate wording, or maybe what recommendations are not helpful. So we would encourage anyone who's interested in the voluntary assisted debate to go to our policy paper, and please get in touch with us if you have any comments, observations, or if you want to ask our group any questions.
Thank you, Mark.
Thanks, Andy.